everyone, we are here to discuss the subject-wise test in dermatology. A good 100 questions. I'm sure you all have gone through it, so we'll now be discussing these one by one. Moving on to the first question. This has long lines and the options. You know, these questions take up a lot of time, but mostly questions with such long descriptions are easy because they don't want you to think much. They just want you to read and tell the answer. So, which of the following is incorrect about actinic keratosis? Actinic keratosis is an important lesion because despite the fact that it is very uncommon in Indian skin, somehow our question makers are very fond of actinic keratosis. In some form or the other, it's histopath or some other clinical feature, treatment, they will keep asking you questions. Let us first read what actinic keratosis is. See, this is basically a skin lesion which happens due to sun exposure. Actinic, as the name suggests, actinic means sun. So this happens due to sun exposure. Which component of sun exposure? UVB. Now, this is a pre-malignant lesion. That is why it is so important, because it is a pre-malignant lesion. It can lead to the development of squamous cell carcinoma. Now, how does it look like? This looks like a dry, scaly lesion present mostly on sun exposed sites like the face or the hands. If you do the histopath from this lesion, you will see parakeratosis and dyskeratosis with cellular atypia. Parakeratosis means nucleated keratinocytes in the stratum corneum. Dyskeratosis means abnormal keratinization, which leads to some cells with abnormal mitosis and disordered polarity of the epidermis. Atypia, as again, is cells with maybe a large nucleus or a disordered mitosis, different shapes, different architecture. So all these features will suggest that there may be some pre-malignant change which is happening in the lesion. How do you treat? First of all, you screen for squamous cell carcinoma by taking a biopsy. It's very important to establish the diagnosis, see the extent of atypia, or maybe a small squamous cell carcinoma happening somewhere in the lesion. Then you patient to stop or decrease further sun exposure, use good sunscreens, and if I have to treat, I treat it with 5-fluorouracil. It's a topical agent given in the form of a cream. It's a cytotoxic drug. It will kill the atypical cells and the cells which are causing this actinic keratosis, thereby eliminating the lesion and eliminating any chances of malignancy which would have developed within the lesion. Now, what are the important points here? The important points are this, the fact that it's pre-malignant, how does it look like, parakeratosis, dyskeratosis, these are all MCQs. Parakeratosis is seen in 1, 2, 3, 4. Actinic keratosis is one of the options. That's your answer. What is the cause of malignant dyskeratosis? Again, actinic keratosis. 5-fluorouracil as a treatment. So these are all important points about AK. Another important thing is SCC. What are the percentage chances of this lesion developing into SCC? Even though we know it's pre-malignant, it may develop into SCC, but what are the chances? The chances are around 20%. So only around 1/5 of the lesions will develop into a malignant lesion. This is something that is important because we should be aware, that a malignancy may happen, but it is not as common. I have an image to show here. See, this is a lesion of actinic keratosis. A dry, scaly, small plaque. May not even identify. You identify only when it has a small erosion and an ulcer, it has transformed into SCC. So this is actinic keratosis. Very, very important question for the purpose of your MCQs. Now, coming back to the question, which of the following is incorrect about AK? This is the most common pre-malignant skin lesion. Correct. Dry, scaly, brown area indistinguishable from SCC. Correct. Approx 80 to 85% of AK convert to SCC. No, the answer is only 20%. Most actinic keratosis treated with 5-FU cream. Yes. So the answer to this question is option C. All right. Good. Moving on to the next question, question number 2. Which drug is most commonly implicated in drug-induced pemphigus? Drug-induced pemphigus is quite a commonly asked question. If we think about the drugs that induce pemphigus, there are 3 important categories of drugs that cause it. Thiol group, the non-thiol group, and phenol drugs. In the thiol group, you have penicillamine. In the non-thiol, you have the ACE inhibitor, captopril, while in the phenol group it is rifampicin. I am only listing the drugs which are most important. Okay, so penicillamine and captopril are the most common drugs which are implicated in causation of drug-induced pemphigus. Out of these, the most common is pemphigus, which is what the question is asking us. So most common cause of drug-induced pemphigus is penicillamine. Around 7% of the patients who use penicillin have pemphigus. And what are the patients who take penicillin? Generally the patients with connective tissue disorders like SLE or rheumatoid arthritis. They are started on this drug, maybe in a year or so they develop multiple bullae and oral ulcers. Treatment: stop the drug, treat the pemphigus while it has it. It will resolve on its own once you cessate the trigger. Right? So the answer to this question is the most common drug. Penicillamine is my answer here, option A. What are the other side effects that you have to remember about penicillamine? The other side effects are it can cause both hypo and hyperglycemia. That's another question that comes from pharmacology. The third question for the day, identify the disorder. This is an image-based question. It is giving you just the image. There is no hint at all in the text. What does it show? It shows us that it's a small face, so it's probably a child, right? Yes, that's difficult to judge, but a little face, probably a girl. What does she have? As the arrows are pointing, there are hypopigmented macules. See, that is what is the only thing I can make out in the text. These macules are multiple. They are present on the cheek. So this is the entire information that I am getting from the question. The text is irrelevant. Image just gives me multiple hyperpigmented macules on the cheeks. I can't make out any scaling. I can't make out any other finer changes. Now let us look at the options. My options are verruca plana, P. alba, which is pityriasis alba, tuberculoid leprosy, and scrophaloderma. So now if I come to the differential diagnosis of a hypopigmented macule on the face of a child, what will be my options here? So my options here are number 1, pityriasis alba, number 2 is indeterminate leprosy, and number 3 is pityriasis versicolor. So these are mostly, like this question doesn't give us these options, but I'm discussing about a question which will actually have one of these 3 options, and they are difficult to distinguish. Most important differentials for hyperpigmented macule on the face of a child. Now, how will these look like? This will generally be multiple, present on both cheeks, macule associated with fine scaling, and there may be a history of episodic occurrence, means they may recur, common in children who have history of atopy or atopic dermatitis. Now, if we talk about indeterminate leprosy, this is again seen on the cheek, but it is mostly a single lesion. A hypopigmented macule with no scaling and normal sensation. There will be generally history of a endemic region in the residence of the child. So the child may be coming from an endemic area like Bihar, Jharkhand, Chhattisgarh. That will be present mostly in the history. Moving on to pityriasis versicolor. This will be generally multiple lesions which are polycyclic, means they coalesce. They will also be hypopigmented but have scaling, and they will not be present just on the face, they will be also present on the upper back and the chest. There may be history of occurrence in hot and humid temperature. So this is what will be the hint about pityriasis versicolor. Most importantly, you differentiate between these 3. Now, as per our question, multiple hypopigmented macules in the face of a child, the most probable diagnosis amongst these options will also be pityriasis alba only. Verruca plana is a viral wart infection. I have images to show so that you compare. Tuberculoid leprosy is again a hypopigmented macule of leprosy. Scrophaloderma is an entirely different thing. It doesn't fit into the differential at all. It is a very easily eliminatable option. Now, moving on to pityriasis alba. This is again an image which is a more classical image. As you see here, multiple lesions on the face of a child with fine scaling. Verruca plana, as was the option, so I have given the images here. These are multiple flat topped shiny papules, may show features of pseudo cobnerization, as you see in the image here, caused by HPV 3 and 10. So this is what you need to know about verruca plana. Doesn't at all look like what the image in the question was. What was the next option? Tuberculoid leprosy. Yes, tuberculoid leprosy can present as a hypopigmented macule or a plaque, but here it will be anesthetic. There will be a loss of sensation and there will be no sweating, no hair in the lesion, plus it will mostly be a single one. Could be anywhere on the body, the face, the arm, the leg, the shoulder, but it will be a single lesion with loss of sensation, not what the image there tells us. The last option in the question was TB scrophaloderma, entirely different thing. This is an ulcer with a blue margin and pus positive for AFP. So scrophaloderma is entirely different, not a good differential, but still I have included it here so that you come to the, so that you see what all of these look like. So the answer here is pityriasis alba. Clear to everyone? Good. Now moving on to question number 4. This is discussing porphyrias. Porphyrias is a topic that I don't really like, and I'm sure even you don't like much, because every time to remember every enzyme which is causing this porphyria is a difficult thing. But Porphyria cutanea tardia is the easiest of all the porphyrias. So let us see what it actually is. Porphyria cutanea tarda. This is the most common porphyria in humans. That is the first thing that you have to know. Then, which is the enzyme? Decreased activity of uroporphyrinogen decarboxylase. Generally of two types. One is the sporadic and the other is inherited. Generally happens in those who ingest a lot of alcohol or have taken OCPs or have hepatitis infections. Inherited is autosomal dominant. Generally there is a family history present. So these are mostly the two types of PCT that you need to remember. The sporadic one has later onset, while the inherited has early onset. Tarda means late. So this is one of the porphyrias which may generally not show immediately at birth. Unlike the other porphyrias, this can also happen later in life. That is why it is called as tarda. Now, what are the clinical features? Clinical features, you have photosensitivity, then you have blistering on these areas which are exposed to sunlight, face, hands and feet. When it heals, there may be a little hypertrichosis on the face, then a skin thickening, which is like scleroderma. Actually, the patient may look like a wolf, so it is also called as wolverine facies. The skin is very thick, there is a lot of hair on the face, it appears as if it's a wolf standing in front of you. So this is Porphyria cutanea tarda. You can measure the urine porphyrin excretion, plasma porphyrin assays. These are all the investigative test. How do you investigate. You may have urinary porphyrin assay. You may do plasma porphyrins. You may do Wood's lamp of the urine, the teeth, the eyes. Then how do you treat? You treat by 1, photoprotection, 2, repeated phlebotomies. This is to decrease the hepatic iron content. And 3, sometimes we use a drug which is called as HCQS, hydroxychloroquine. So these are just some points which we have to remember about PCT. I have some images to show to you. These are the blisters which are developing on the hands and the feet. And this is the face which shows hypertrichosis, that is increased hair and thickening of skin. This is also called as the Wolverine facies. Now coming back to the question, let us go through these options. Which of the following is not true? So it's asking us what is not true. It is the least common type of human porphyria? No. I just told you it is the most common. Decreased activity of enzyme uroporphyrogen decarboxylase? Yes. Prior Hep C virus is an independent risk factor? Yes. Treatment is repeated phlebotomies? Yes. So all the other options are correct, while the option A is our answer here, as it is the most common type of human porphyria. Clear to everyone? Good. So moving on to the next question. See what this image is telling us. Again, there is no hint in the text. Let us see what it is. It is a child, could be a newborn, who has an erythematous, mostly a macule. It doesn't look raised. Macule on the nape of the neck. So this is all that is given in the option here. Now, what is it? This is a salmon patch. What is a salmon patch? This is just a vascular ectasia. Ectasia means it is a dilatation of blood capillaries. It is most common in newborns. Most common site is the nape of neck, where it is called as the stork bite, or and the glabella, where it is called as angel's kiss. Right? It looks like a red macule, and it is mostly bilaterally symmetrical. So if it is in the glabellar region, it will be bilaterally symmetrical. In the nape of neck also bilaterally symmetrical. Asymptomatic, will disappear in about 1 year. So if you remember Hindi, if you all know Hindi, then salmon patch has this SAL. SAL in Hindi is Sal. So this will disappear in around 1 year of patient's life. It is just a vascular dilatation and ectasia. It is not a malformation. It is not a tumor. It is only a capillary dilatation. Stork bite. Now, what are the other options in our question here? The other options are port wine stain, hemangioma, lymphangioma. All these look very different. I have included images to show to you. We'll be seeing them in a short while. Just look at this image for now. See, this is the child who has this erythematous patch somewhere in the midline, bilaterally symmetrical, very irregular shape, not raised. This is salmon patch for you. Now, I have included other images. Hemangioma is one of our options. See how hemangioma looks like. It is a swelling. It's a tumor. So it has to be raised. It is a raised swelling. Generally is not present at birth. It appears a few months later and then keeps increasing in size till maybe 1 to 2 years, after which it starts resolving. So that is how the natural history of hemangioma is. Clear to everyone? Great. Now, what was the next option in our question? The next option was a port wine stain. What is a port wine stain? This is a capillary malformation. This is generally unilateral, so there will be a midline demarcation, and it will be an erythematous lesion, but it may be slightly raised also. If I put a slide on it, it is non-blanchable, and P for P, it will persist all life. It will never resolve. So this is a port wine stain for you. And you also need to know the syndromes that are associated with all these hemangioma. You have the faces or the faces syndrome. Then with port wine stain, you have Sturge-Weber, Klippel-Trenaunay syndrome. So these all also you need to be aware. One more point with port wine stain is, what is the site? The most common site are V1 and V2, supplied by the trigeminal nerves. So V1 is the ophthalmic, V2 is the maxillary. This one is a V2 site. So these are the most common sites for port wine stain. The third option that we had in the question was a lymphangioma. Lymphangioma is actually a tumor of the, it's actually a tumor of the lymphatic channels in the dermis. So this looks like clear fluid-filled vesicles. So that's how a hemangioma looks like. Again, nothing what the image gives you. So is this clear? These are just some additional options so that you know how these look like. Now moving on to the next question, Zank smear. Question number 6. Zank smear helps us in the diagnosis of. Okay, I can see two options which may sound slightly as the answer. So one of them is the answer and the other one is also an answer. So we have to choose the best option here. Now let us see what a Zank smear is. Zank smear is a cytology test generally done in vesicular diseases. This is a vesicle. I will unroof it like this. Then this raw area I am going to scrape and put it on a slide, smear it with Giemsa stain, look for certain cells. Okay, so a vesicle is unroofed, scrape the erosion, put the material on a slide, stain it with Giemsa, and then look under the microscope. That is what you do in zinc smear. Now, what are the uses of zinc smear? The uses that you need to know is, number one, pemphigus. In the pemphigus, these are your intra-epidermal vesiculobullous diseases. What do I see? I see the acantholytic cells. This is what I see here. Round cells with a large nucleus. In the pemphigoid group, which is a bullous pemphigoid, you see no acantholytic cells, but you may see eosinophils. Okay, see here. See, this is your pemphigus. You see these round cells, which are your acantholytic cells. These are actually keratinocytes, and they are also called as zinc cells. Okay. Now, amongst the other uses are your viral vesicular diseases. What are the viral vesicular diseases? Which are caused by HSV, then which are caused by VZV. What is caused by HSV? You have herpes labialis, you have genital herpes, then eczema herpeticum. Okay, these are cells which these are the diseases caused by HSV. Then what does VZV cause? VZV causes one, chickenpox. VZV is varicella zoster virus, and it causes herpes zoster. So in these viral vesicular disorders also my zinc smear is positive. What does it show? It shows this. What is this? This is a multinucleate giant cell. This is a MNG. This is another use for zinc smear. Clear to you all? So mainly two uses are your intradermal autoimmune vesicular disorders like pemphigus and viral vesicular disorders. Bullous pemphigoid, I don't use it for diagnosis, I just use it for ruling out pemphigus. So even though it will be used here, but the correct answer to this question is A, herpes viral infections. Carcinoma of the cervix, no. Bullous pemphigoid, not for diagnosis. Obviously not. So the answer is option A. Moving on to the 7th question. Which of the following is considered as a high risk susceptibility gene for malignant melanoma? High risk susceptibility gene for MM. Now, this is a fact based question. I will call it difficult because malignant melanoma is not something that we give a lot of importance to. It is generally the last tumor in most of the books. We skip it like that. So it's an important question as it is dealing with a not so studied tumor, malignant melanoma. Now whether it is CDKN1A, 2A, 3A, 4A, a totally fact-based question, nothing much to explain for me here. The answer to this is CDKNA2, present on chromosome 9, is the best established high-risk locus for malignant melanoma, found in up to 40% of individuals with a familial disease. So please remember CDKN2A, just remember 2A for malignant melanoma. Alright, now with malignant melanoma, we generally don't get a lot of questions, but what all do you have to remember? You have to remember for MM, what are the pre-malignant lesions? The pre-malignant lesions are a giant congenital melanocytic nevus and dysplastic nevi. This is a tumor of melanocytes. So this will be found not just in the skin, it can be found in the eye, in the meninges, wherever you have melanocytes. What are the types? The most common type all over the world is the superficial spreading type. Which is the most common type in Asia or India? That is the acral lentiginous melanoma. Which is the best prognosis? The best prognosis is for lentigo maligna melanoma, because this is actually SCC in situ, it has not yet spread. So these are just some important questions that you need to remember about this. Apart from this, what all do we have to remember? We have to know how does it spread. It spreads by lymphatic channels, okay, spreads through the lymphatic route. So here in the question, the answer is option B, CDKN2A. The next question, which of the following biologic agent is approved for treatment of psoriasis or psoriatic arthritis and is not anti-TNF alpha? So the important point in this question is which of these is not anti-TNF alpha. Now, if we read the biologics that are used in psoriasis, first and the foremost, most important category is the anti-TNF alpha drugs, because these are the most commonly used and the most effective. Here you have infliximab, etanercept and adalimumab. These are the most important anti-TNF alpha drugs that you use in psoriasis. Now, what are the other categories? Then the other drug is elifacept. This is an anti-LFA3 drug. Then you have Ifalizumab, this is anti-CD11A. Then you have secukinumab, ustekinumab. Secukinumab is anti-interleukin 17A, while ustekinumab is anti-interleukin 12-23. So these are all important drugs that you need to know about psoriasis or psoriatic arthritis. Alifacept, ifalizumab, secukinumab, ustekinumab. These are the not anti TNF alpha drugs. There is just another flowchart which is listing out all of these. There's one more entity which we didn't write there, that was apremilast, which is anti-PDE4, which is phosphodiesterase 4. This is actually an anti-emetic drug, but now it has been seen to improve psoriasis also. It has been recently approved in 2014. Rest of the other drugs we have already mentioned. So these are the main biologics used in psoriasis. The question is a little tricky one because it is asking you the drugs which are not anti-TNF alpha. So generally we remember the biologics used in psoriasis, but to remember it like this is the way it is supposed to be. So etanercept is anti-TNF alpha, infliximab and adalimumab are again anti-TNF alpha. However, alifacept was your anti-LFA3 agent. So the answer here is B. Clear to all? Yes, alifacept. This is just another list which is mentioning these drugs only, nothing much in this. Moving on to the next question, Menkes kinky hair disease. Now what is Menkes kinky hair disease? Do you have any idea about it? It is again a difficult question because it's dealing with a disease that we don't really read on a daily basis. This is an often skipped topic. So good to include it here so that we can study it. What is Menkes kinky hair disease? I have a small cartoon which is telling us what it is. So this is basically a X-linked disorder, as the chromosome here tells us. This is an X-linked disorder, more common in the males. There is a defect in this enzyme ATP7A which leads to low absorption of copper and in the skin, which will reduce your levels of copper in the body. Now what happens when you have these reduced levels of copper in the body? There will be effect on the brain, so there will be a progressive cerebral degeneration. Your skin and hair will be damaged due to the low copper, which will lead to your kinky hair. Then the bones will be damaged. You'll have scurvy-like bone changes, anemia, neutropenia, growth retardation, failure to thrive. A lot of these will happen in the baby, due to which it will be a difficult survival. And increased copper secretion from the kidney will also damage the kidneys. Now, what is important for your MCQs? Important for your MCQs are these hair, the kinky hair. These have slight bent due to the brittleness of the hair. So, kinky hair disease. Now, let us just write it down. This is an X-linked defect in the intestinal absorption of copper. The enzyme involved is ATP7A. Due to the low levels in the body, you will have progressive cerebral degeneration, kinky hair which is sparse, brittle hair, scurvy like bone changes, anemia, neutropenia. So these are mostly the findings that you will observe in Menkes disease. Now what is important? You are asked the inheritance, the enzyme, low levels of copper and ceruloplasmin both. These both will be reduced. You'll have kinky hair. So this is what is generally asked. Have a look at the cartoon again. This will help you remember. Menkes disease. This is how the hair look like. Alright? So moving on to the question. Menkes kinky hair occurs due to, this occurs due to low copper levels. So the answer to this question is option A, low copper levels. Moving on to the next question, question number 10. This is again an image-based question. Nothing much is written in the text. Let us see what it is. This is the photo of a face. I don't know if it's a male or a female. So photo of a face. What do I see here? Sorry. What do I see? I see a hyperpigmented lesion on the face. It's mostly a macule with speckled pattern present bilaterally on the cheeks. Then it is also present on the nose and the upper lips. This is what I make out from the image given to me. Now, what is that lesion in dermatology which looks like a hyperpigmented lesion present bilaterally on the face, of the cheeks, the nose, the upper lips, could be present on the forehead? What is it that you know? That is nothing but, it's nothing but melasma. So this is melasma for you. This is an important hyperpigmented lesions because you don't have many hyperpigmented lesions. Hypo, yes, are present in plenty in dermatology, but for your level, amongst the hyperpigmented lesions, you only have melasma, freckles, ephilids or the lentigo, a few nevi like the Becker's nevus, nevus of Ota, Ito, and melasma. That's it. So amongst the hyperpigmented lesions, it is the most important for the purpose of MCQs. And it is exactly what I have written here. It is on the face, has 3 most important causes with it, that the visible light as well as the infrared radiation are also important for causing melasma. The second thing that you have is your hormones. What are the hormones here? The hormones are some drugs that you have like OCPs or the hormones that you find in pregnancy. So these are the 3 most important causes of melasma. When it happens in pregnancy, then it is also called as chloasma. So please remember these three causes, very, very important. How do you treat melasma? You treat it by number one, giving sun protection. The patient has to use a scarf, umbrella, or a sunscreen. Number two, medicines, in which the most important medicine is hydroquinone. This is a topical tyrosinase inhibitor, which given in the form of a cream in a percentage of around 2% to 5% is effective agent for treatment of melasma. Another thing that we give is a thing which is called as the Kligman regimen. What does Kligman regimen include? It includes a topical retinoid plus a topical steroid plus hydroquinone. So these are three components of Kligman regimen which you are supposed to remember. Other than this, we also use chemical peels. आपको question आया हुआ है on glycolic acid peels. Then some other drugs which you will read in pharma are azelaic acid, kojic acid. These are also depigmenting agents used in the treatment of melasma. All that you need to know is already discussed. Now let us come back to the question. See what it is asking. It's asking us what is false. So what is not true? Is it more common in the male? No, not at all. It is more common in the females. Hydroquinone has a role in treatment? Yes. Oral contraceptives are important? Yes. All are true? No. So the answer to this question is option A. It is more common in the males. Right? Good. Coming back to this question, coming back to the next question, which is a feature of Gorham's disease? What is Gorham's disease? Hyperpigmentation, cutaneous hemangioma, alopecia, photosensitivity. What is this? See, Gorham's disease is also called as the disappearing bone disease. This is also called as the disappearing bone disease. This is a slightly difficult question because we don't normally read Gorham's disease on a routine basis. It is one of those topics which are very easily skipped. So it's a flash question. You read it here, you'll always have it in your mind. If at all you get a question like this in the exam, you'll be in a good position to answer it. So this is also called as the disappearing bone disease. What happens here is you have multiple hemangiomas. These hemangiomas are present on the skin as well as in the bone. So what happens when these hemangiomas are present in the bone? Suppose this is my bone and I have a lot of hemangiomas inside it. So due to the increased vascular supply, there will be faster resorption of the bone. Okay, so there will be a faster resorption of the bone, due to which the bone will disappear. It's as if it is completely resorbed and it is disappearing, leading to multiple fractures and bone pains. So the main complaints that this patient will come to you with is pathological fractures and bone pains. This is due to the disappearance of the bone because there is increased blood vessel, calcium will be absorbed, the bony matrix and everything will just keep disappearing, and if you perform the x-rays of the patient, In one X-ray there is a bone, maybe a few months to years later you do the X-ray again and there is no bone because it is almost disappeared due to the resorption. So what is it that you find here? You have hemangiomas in the skin and the bone. Now coming back to the question, in the question hyperpigmentation, no, it is not seen. Cutaneous hemangiomas, yes. Alopecia, no. Alopecia means the bone is not formed. No, that is not correct. The bone has formed but it is also disappeared. Photosensitivity, no. So the correct answer here is option B, cutaneous hemangiomas. Clear to everyone? The disappearing bone disease. Coming to question number 12. In the question number 12, this is again an image based question. Dermatological test shown in the image. So what do you see in the image here? I see that there is probably a lesion on the arm or the thigh. It is a depigmented lesion and the examiner is pressing a glass slide on the lesion. So this is a test where the person is putting a glass slide on the lesion. What do you think it is? Is it Woods lamp examination? No. Is it patch testing? No. Is it diascopy? Yes. That is the answer. Is it a Blanch test? No, there is nothing which is called as a Blanch test. You just press on the thumb and you see whether it is blanching or not, but it is not given a specific name as a Blanch test. So that is a non-existent test. Amongst these options, the answer is diascopy. Now, what is diascopy? Diascopy is a bedside test where you press on the lesion with a glass slide. Okay, what do you look for? You look for whether it is blanching, whether the pigment is disappearing, reappearing. All these are features which you look for in diascopy. See this, I have this for you here. This is an erythematous lesion. I am pressing on it, seeing if it blanches or not. Then it's not visible here. Here again there is an erythematous lesion, blanching to see what are the changes that happen. At your level, what all is asked with respect to diascopy is one, it is done in lupus vulgaris, where you see apple jelly nodules. Then it is done in sarcoidosis, where the appearance is called as the sarcograne appearance. In number 3, we have the differentiation between nevus anemicus and nevus depigmentosus. You have to differentiate between these two. And the fourth entity where you use are the erythematous lesions to see whether they are blanching or not, and in vasculitis to see whether it is purpuric, again it is blanching or not. So these are the main uses of diascopy in dermatology, in which you get a question on this and this. So these are the most important uses of diascopy at your level, and all of these are questions. Moving to the image, this is how a diascopy looks like. Then what were the other options? The other options were Wood's lamp and patch test. I have also included the images of that here so that you identify those when given in the question. See, this is what a patch test looks like. You have multiple patches applied on the upper back of the patient. This can also be an image-based question. They ask you to identify what is happening here. Then Wood's lamp would look like this. So this is the appearance which you get on Wood's lamp. If such kind of a photo is given to you, then it means that the test being conducted is your Wood lamp examination. All right? So this is that. So moving to the options of our question here, the answer either way is diascopy. I hope I am clear. Moving on to the next question. True about pityriasis rubra pilaris. Isolated patches of normal skin found, cephalocaudal distribution, IV cyclosporin, oral cyclosporin. So what is pityriasis rubra pilaris? Let's read a bit about the same. This is a papillosquamous disorder. This is generally seen in the adults. There are 6 variants of PRP, but at your level it is mostly seen in the adults. Starts as erythematous follicular papules. See the name is suggesting pityriasis means scaly, rubra is red, pili is hair. So it starts as erythematous scaly follicular papules which will gradually spread leading to erythroderma, which is more than 90% of the skin is red and scaly. So this leads to something which is called as erythroderma. Now, what are the specific features for the purpose of your exam that you need to remember? You need to remember that the erythroderma here is orange in color. Secondly, it has skip lesions, means there are isolated patches of normal skin found in the lesions. Thirdly, there is a sandal keratoderma, means there is an orangish thickening of the skin of palms and soles. And you have nutmeg papules. These are spiny hyperkeratotic papules on the knuckles. Okay, so this is what you need to remember about PRP. Question is generally on this erythroderma, then the skip lesions and sandal keratoderma. This is what is generally asked to you in the exam. One more point is how this spreads. This spreads in a cephalocaudal pattern, means top to bottom. This is the pattern of spread of the lesions. Now I have an image also to show you. See this image here. This is the orangish keratoderma. Notice these lesions here. I am zooming again. See here. Do you see these tiny patches of normal skin in between. Here also you see normal skin. So this is what we mean by skip lesions. And then you have this sandal, which is the orangish keratoderma, thickening of skin of palms and soles. What is the treatment? Treatment is high dose methotrexate or acitretin. These are the two treatment options for PRP. Now let's look at the question. What is it asking us? What is true? So isolated patches of normal skin found? Yes. Cephalocaudal distribution. See, it is not actually a distribution. This is a cephalocaudal spread of the lesion. So it is not a distribution per se. IV cyclosporin is effective? No. Oral cyclosporin? No. So the correct answer to question number 13 is option A. Isolated patches of normal skin are found. PRP is important because it is asked almost every 3-4 exams. They will give you a question on PRP. Image can also be given. Identify the skip lesions. That will help you in arriving at the diagnosis. Moving to the next question. Question number 14. Now this is a long question. Let's go through it together. This is a healthy young adult male. So this is a healthy young adult male who presents with multiple irregular, painless, non-itchy brownish pigmentation on the lower leg. No history of trauma, physical examination normal, lab test normal. What is the diagnosis? Yeah, this is a slightly difficult question because we generally don't read these topics on a routine basis. There is a slight spelling error in the question here. This is lichen aureus, not purpureus. There is no entity as purpureus. This is lichen aureus, Hinault-Schönlein purpura, Schamberg's disease, and Tinea pedis. So these are the 4 options. What is the answer? What we are discussing here is an disease entity which is called as pigmented purpuric dermatosis. This is the blanket disease term which involves a lot of entities which are also the option here in our question. Generally happens in adults who are otherwise healthy, males more than females. Here what happens is there is a venous dilatation. So there is a vein defect. What does this lead to? This leads to dilated veins leading to extravasation of blood into the skin. Now this blood has hemoglobin which is metabolized and sometimes reabsorbed, but other times it can get deposited in the skin as hemosiderin. So what is happening is that you have veins which are dilated, the RBCs move out into the skin. The RBCs, when they move out, they release their hemoglobin. Hemoglobin is metabolized, it is reabsorbed from there, good. But when it is not metabolized, it stays there. Sometimes that hemoglobin can convert it to hemosiderin, which stays in the skin, leading to a rusty brown pigmentation in the skin. So this is what we mean by a pigmented purpuric dermatosis, blood deposition in the skin. Now, the most common type of PPD is Scheinberg disease. This is the most common type of pigmented purpuric dermatosis. You see multiple asymptomatic brownish macules on the lower limbs. They may also have some mottled pigmentation, which is called as the cyan pepper appearance. So this is what is Scheinberg's disease, asymptomatic completely. The only problem patient has is there are visible lesions on the feet and which are not cosmetically very pleasing. What were the other options for us? The other options were lichen aureus. This is also a type of PPD, but it is seen more on the hands than the feet. Generally a solitary lesion which is itchy and it appears golden brown in color. So lichen aureus is also a type of PPD, but a single round lesion like this. The other option in the question was purpura annularis telangiectasis. This is also a type of PPD, but here we have annular lesions. Annular means round, which have multiple telangiectasias, and they extend from the feet to the leg. They move proximally and sometimes even up to the thighs, and they can be itchy. So that is purpura annularis telangiectoides. Slight telangiectasias can be seen within the lesions. The fourth option in the question was Hinoch-Schönlein purpura. I have added the image here to show to you that this could be a differential, because here also lesions are seen on the feet like this, but they are palpable purpura. They are purpuric, means they are reddish purple. They are not brown. They are reddish purple lesions, and they are seen on the legs, the thighs, the buttocks, associated with abdominal pain, arthralgia, blood in the stool. It is an acute type of vasculitis most commonly found in children. So this is most commonly found in children, not in healthy adult males. Clear? So even by the virtue of image, by the text, we come to the diagnosis. The diagnosis here for our answer is Scheinberg's disease. Multiple asymptomatic non-itchy brownish spots on the lower leg. Tinea pedis would be itchy, erythematous, annular plaques. Clear to everyone? Good. Moving on to question number 15. This is a question which is thankfully giving us some hints in the text also along with the image, only one of its kind till now. Yeah, let us read what it is giving us. Here it is a child Comes to dermatology OPD with similar looking lesions over the elbow and the penis. What is the diagnosis? So a child with similar looking lesions on elbow and shaft of penis, easy one if you know this disease, and these days it's quite a common question, so I'm sure you know it. Which of these options, lichen planus, lichen scrophalosorum, scabies, or lichen nitidus? What is this? This is nothing but lichen nitidus. Now what is this? This is generally seen in children. You have multiple skin colored to slightly hypopigmented pinhead size discrete papules which are present on generally the extensors like elbows, knees, and the penis. These are completely asymptomatic. There is no complaint by the child. Now, look at this. This is how it looks like. Multiple hypopigmented discrete papules on the extensors and the penis. Now, what is the histopath? The histopath shows a clutch and ball appearance of the band-like inflammatory infiltrate. Means these are my retiridges and my infiltrate is somewhere here. So it's as if it is clutching the inflammate in its hands. So clutch and ball appearance of the inflammatory infiltrate. Treatment, this is generally a self-resolving disorder. So it's a self-resolving disorder. This is the image of the hand and image of the penis is given in the question itself. So this is how your lichen nitidus looks like. Coming to the other three options, how does lichen planus look like? Lichen planus looks like this multiple violaceous, itchy papules. Lichen scrophalosorum is actually the closest differential for lichen nitidus. Why is it the closest differential? Because here also you have multiple tiny papules which are present in a grouped pattern on the trunk. So this is what you have to actually remember. They are present in a grouped pattern on the trunk, lichen scrophalosorum. Now I'll tell you a tiny bit of difference. In lichen scrophalosorum, these lesions are follicular, means they are arising around the hair like this, while in lichen nitidus they are non-follicular. Such a close difference nobody is asking you. Just identify the image. Can you see the difference in the image here? There they were spread all over the elbow. However, here they are present in a grouped pattern, not as uniform type of distribution over the entire trunk. This is lichen scrophalosorum. This is actually a id eruption to tuberculosis infection in the body, lichen scrophalosorum. And the fourth option was scabies. Scabies would also give you papules, but the papules and scabies would be in the finger webs, the wrist, the cubital fossa, axillary region, and the periumbilical area, which is called as your circle of Hebra. And it would be extremely itchy. In the question it mentions they are not mentioned, but still. So coming back to the question, the answer is lichen, and it is option D. Clear? All the other options you can exclude as it is. Moving to question number 16.